In this section, I gave a presentation on the influence and treatment of hormone-sensitive metastatic prostate cancer, and touched on a number of issues relating to the timing of treatment and the type of treatment, in addition to the subsets of patients that present in such a way. What we know from population-based figures, and we've got very good figures in England and Wales here in the UK, is that approximately 16% of men present as their first presentation with metastatic prostate cancer. And they're clearly hormone naive. There is a second group of patients who go on to develop metastatic prostate cancer who've been previously treated either with surgery or radiotherapy. They tend to behave somewhat differently. It's a rather less aggressive cancer than those presenting initially with metastases. But they all require treatment. What we know from a number of studies now that have been published is that early treatment in the hormone-naive setting results in a much greater benefit than late treatment when the patient becomes castrate-sensitive. And that treatment is combination therapy, either with chemotherapy or with novel hormone agents. There is the secondary question of the benefit of radiotherapy to the primary site, and in whom do we give this treatment to. So if we look at the early papers, which were looking at Docetaxel, these were the latest publication of the primary data was in 2015. We showed unequivocally that the addition of Docetaxel in standard dose, 6 cycles, standard dose Docetaxel given with ADT, which is standard therapy for all, resulted in a major improvement in overall survival. And this was followed then by the 2 synchronously published major papers in the New England Journal of Medicine looking at the use of Abiraterone. The difference in the 2 papers, which were LATITUDE and STAMPEDE, was that LATITUDE had a risk criteria applied to it, whereas the STAMPEDE trial gave the combination treatment to all patients. What we showed is that the volume of disease, or the risk of disease, in other words, the burden, really wasn't influential, and that benefit was gained for all patients, no matter whether they had high risk or low risk according to LATITUDE criteria, or high risk or low risk according to charted criteria. And this has been subsequently confirmed in other studies using novel hormone agents such as Enzalutamide and Apalutamide. So if you give the treatment, you get the benefit whether it's high or low burden. The second issue is whether to give radiotherapy to the primary site in the presence of metastatic disease. And here disease burden is influential, and this has been shown conclusively by a post-hoc analysis of the STAMPEDE trial, whereby the images using standard imaging, that's standard bone scan and CT, were centralized, analyzed, and reported in relation to the number of bone metastatic sites, 1 metastasis, 2, 3, 4, 5, and so on, looking at failure-free survival and overall survival. This was the basis of a 2018 publication on STAMPEDE data, which showed that if a threshold value of 5 bone metastases on standard imaging was used, then radiotherapy to the primary site was beneficial. But once the patient had a greater volume of bone metastatic disease, then that influence was lost. And this was predictive, it wasn't prognostic, which is an important factor. The STAMPEDE went on through 2 research fellows, Adnan Ali and Alex Hoyle, working in the Christie in Manchester, who then did a systematic analysis looking at burden. This was published in the Journal of the American Medical Association Oncology section, which showed that rather than this being a dichotomous variable, it was a continuous variable. In other words, if one had 1, 2, or 3 bone metastases, the benefit was much greater in terms of overall survival than if one had 4 or even 5. And beyond 5, that benefit started to decrease quite substantially. For failure-free survival, the extent of benefit was even greater. So that has enabled us to establish rules for disease burden and treatment, and set up the next phase of studies, which is to ask the question, does combination treatment with ADT plus chemotherapy or a novel hormone agent plus radiotherapy as the primary, is there additive effect in local treatment for the oligometastatic sites with radiotherapy? And these trials are planned and are due to start. We hope that that will add benefit in a way that those trials have done so incrementally since their publication. Thank you.